Good morning, everyone. Myself, Dr. Lasker, Senior Lecturer, Department of Oral and Maxillofacial Surgery, Index Institute of Dental Sciences. Today, we will discuss on oral antral fistula or oral antral communication. So, what is oral antral communication? An oral antral communication is an unnatural communication between oral cavity and maxillary sinus. And what is oral antral fistula? An oral antral fistula is an epithelialized, pathological, unnatural communication between the oral cavity and maxillary sinus. The accidental production of an oral antral communication is probably a relative common occurrence during the extraction of maxillary posterior teeth. Extraction of first molar and second molar are most likely to be complicated by the production of breach of floor of maxillary sinus. Oral antral communication also occur during the removal of third molars and second premolars. Occasionally, first premolars and even canine also cause the oral antral communications. The proximity of maxillary second premolar and first molar to maxillary antrum is of great importance. Now, what are the causes related with oral antral communication? The oral antral communication can result from several causes: extraction of teeth, extensive trauma to face, surgery of maxillary sinus, removal of large cystic encroaching on the sinus cavity, osteomyelitis, that is chronic infection of maxillary sinus. Gummatous lesion involving palate, that is teratomatous destruction of maxilla, infected maxillary implant denture, destruction of portion of floor of the sinus by periapical lesions, perforation of floor of sinus and sinus membrane with injurious use of instruments, forcing a tooth or a root into the sinus during attempted removal. The vast majority of oral antral fistula results from dental extraction. Up to 10% of upper molar extraction may create oral antral communication, but very few, only 0.5% persist to become fistula. Other causes include malignant neoplasm arising in oral cavity or in antrum. Extraction. The most common cause of an oral antral communication is the inadvertent opening of maxillary sinus during the extraction of maxillary tooth. Rarely, the extraction of posterior teeth associated with periapical diseases. Example, acute periapical abscess, chronic granuloma, periapical sclerosis. The above periapical diseases is at risk of causing oral antral perforations. A conical maxillary third molar, which when grasped with forceps during extraction, slips into the maxillary antrum along with the fracture of the tuberosity and creates an oral antral communication. The different event of removal of teeth also creates an oral antral communication. The event of removal of teeth are as follows. Impacted tooth, example, maxillary third molars, supernumerary teeth, submerged root tooth, geminated tooth, divergent root teeth. Blind instrumentation without adequate surgical exposure may result in the root displaced into maxillary sinus through antral perforation. Extensive trauma to face. Extensive trauma to middle third of face skeleton, especially if the trauma is due to sharp objects driven through the mouth into sinus, will lead to oral antral communication. The penetrating injury, as in gunshot, may result in huge defect of sinus wall that's lead to oral antral fistula. Surgery. The various major surgical procedure leads to formation of large oral antral communication are as follows: partial maxillectomy, surgical treatment of large maxillary cyst or abscess, wrong diagnosis, improper planning of incision, fracture of zygomatic complex. Partial maxillectomy. The partial maxillectomy is performed for eradication of malignancy or antral neoplasm. The partial maxillectomy usually involves removal of alveolus, part of palate, antral and medial walls. Surgical treatment of large abscess or maxillary cyst may lead to formation of fistula. Wrong diagnosis includes marsupialization done for defect in alveolar antral wall. Improper planning of incision for Caldwell loop operations will cause or leads to oral antral communication. Osteomyelitis. The osteomyelitis of maxilla is rare unless there is underlying systemic diseases such as leukemia or diabetes. Uremia, kidney disorder, maxillary region has been subjected to irradiation and severe osteitis with bone loss. Gummatous lesion like syphilis. It is a gummatous lesion of palate may result an extensive oral antral fistula. Congenital syphilis. The lesion associated with secondary and tertiary forms of syphilis. Implant dentures. There can be considerable destruction of antral floor in the patient with maxillary implant denture. Malignant tumors can cause oral antral communication by penetration of lateral walls of sinus into mouth, erosion of floor of sinus into mouth. Symptoms of oral antral communication. Fresh oral antral communication includes those are remembered by 5 E's. First is escape of fluids, epistaxis, escape of air, enhanced column of air, excruciating pain. Established oral antral communications, which are remembered by 5 P's. First is pain, second is persistent, purulent, full, unilateral nasal discharge. Third is post-nasal drip. Fourth is possible sequel of general systemic toxemic conditions. Fifth is popping out of an antral polyp. Fresh oral antral communication causes escape of fluids from mouth to nose on side of extraction. The escape of fluid happens when patient rinse or gargles the mouth following extraction of tooth. In this picture, patient is having a glass of water which is released from nose. There is a perforation in figure 2 seen in the maxillary first molar region causing direct oral antral communication. Epistaxis. Unilateral epistaxis occurs. It is due to blood in sinus escaping through the ostium into the nostril. It may or may not be associated with frothing at the nostril on the affected site. Escape of air from mouth into the nose on sucking, inhaling, drawing on cigarette, puffing the cheek. Enhanced column of air causes alteration in vocal resonance and subsequently change in voice. Excruciating pain. Excruciating pain present in and around the region of affected sinus as the local anesthesia begins to wear off. established oral antral communication symptoms. Pain. Previously, the pain is dominant feature. Pain is negligible as the fistula is established. It allows free escape of fluids. Persistent, purulent, full unilateral nasal discharge. Persistent, mucopurulent, and full nasal discharge from the affected nostril. Discharge occurs especially when head is lowered down. The discharge is unilateral and have foul or fetid taste and smell. Post-nasal discharge is the tricking of nasal discharge from the posterior nares down the pharynx. The continuous swallowing of full mucopurulent discharge may lead to unpleasant taste. Possible sequel of general systemic toxemic condition, fever, malaise, morning anorexia, frontal and parietal headache. In extreme cases, cause anosmia and cacosmia. Popping out of an antral polyp. The persistent infection in antrum may lead to establishment of chronic long-standing oral antral fistula which may be occluded by an antral polyp. This can be seen as bluish red lump extruding through the fistula. This can be antral polyp is seen in this picture. Antral polyp is seen in this picture in the region of upper 6. Physical signs. Those signs presenting immediately after the formation of communication, those relevant to an established oral antral fistula, physical signs of established oral antral communication. early signs, late signs, no examinations. Early signs. The early signs of established oral antral communications are seen when the blood clot get disintegrated so that the breach in the continuity of antral lining remains patent and seal is unbroken. As a result of infection, forceful nose blowing, and excessive rinsing of mouth. Late signs occurs due to involvement of sinusitis or established oral antral fistula with or without rhinitis. Signs and symptoms of sinusitis. Acute sinusitis sign. Tenderness over the maxilla, especially in the infraorbital region. Mild edema of cheek in infraorbital soft tissues. Rarely, rarely, patient gets irachus as a referred pain from antrum. Percussion of maxillary premolars and molars related to affected sinus will lead to pain. Nasal congestion, red, shiny, and swollen mucous membrane around ostium. Presence of pus or mucopurulent discharge in middle meatus. Chronic sinusitis sign. Impairment of impairment of sense of smell, foul smelling of mucopurulent discharge seen under middle concha, mild tenderness over infraorbital region is seen. Escape of air or fluids through nostril. Development of lump or polyp. On examination, discharge of foul smelling pus from the orifice occlude patient's nose and ask him to blow. Careful insertion of an instrument into the antrum, the mass gets pushed to one side and then flow of pus can be seen with blowing of nose. Possible sequel, a newly created fistula is likely to persist if one or more of the following contingencies apply: interference with normal healing process of orifice by instrument or probing of orifice, indiscriminate packing, exploration of socket, vigorous rinsing, injudicious use of caustic substances, introduction of hemostatic agents, traumatic extractions which resulted in soft tissue loss, gross damage to gingival margins, peripheral to the gap, secondary infections of post extractions or a pre-existing sinusitis when the diameter of perforation is greater than 4 mm or the depth of socket is more than 5 mm. Now, management's first treatment of early cases. Ideal treatment, immediate primary closure, antibiotic prophylaxis, ideal circumstance. Perioperative management includes the affected maxillary sinus should be irrigated through fistulous opening with normal saline followed by an iodine containing solution diluted with normal saline, that is 1 is to 1 betadine, to eradicate infections. This regimen should be administered until the lavage fluid is clear and no longer contains inflammatory exudates. Numerous surgical procedures have been advocated for closure of oral antral communication or oral antral fistula. This procedure may be categorized into local flap, distant flap, and grafting. This include rotating or advancing soft tissue such as buccal flap, palatal flap, submucosal tissue, buccal fat pad, and tongue flap. Most of this technique mobilize and advance the resultant flap into the defect. The procedure utilizing buccal mucoperiosteal flap for closure include straight advancement flap, rotation advancement flap, transverse flap, and sliding flap technique, while those utilizing palatal mucoperiosteum are straight advancement flap, rotation advancement flap, hinged flap, and island flap procedure. Double layer closure utilizing double layered closure utilizing local tissue includes combination of inversion and rotational advancement flaps. Double island flaps and superimposition of reverse palatal and buccal flaps. The most common method used for closure of oral antral fistula are the buccal flap and the palatal pedicled flap techniques. Treatment of delayed cases include treatment of oral antral communication within 24 hours of accident, treatment of oral antral communication after 24 hours of accident, treatment of oral antral communication of long duration more than 1 month. Purpose of management. The closure of oral antral communication, the management should be performed. The management should be performed to protect the sinus from oral microbial flora, to protect escapes of fluid and other content across the communications, to eliminate existing antral pathology, to establish drainage through inferior meatus. Treatment of early cases. Cases where oral antral communication is recent and formation of fistula is not established. Ideal treatments includes the immediate primary closure. Ideal treatment includes the immediate primary closure, simultaneous antibiotic prophylaxis to prevent sinus infections. The immediate primary closure includes it is done by simple reduction of buccal and palatal socket wall to allow co-adaptation of buccal and palatal soft tissue. A protective acrylic denture can be used to provide a barrier to the inadvertent entry of food particles. The result of primary closure depend upon skills and experience of clinician. Surgical facilities available, whether the communication is complicated by presence of tooth or root in maxillary sinus or not. Ideal circumstance. Ideal circumstance, that is where patient is under general anesthesia. A surgical procedure can be carried out in operation theater, while the similar is to be performed under local anesthesia in dental chair, regardless of operator skills and experiences and thin facility available and the facilities available. The various procedures can be performed daily. Complete closure of socket. Additional procedures may be required such as reduction in height of underlying alveolar bone, relieving incisions in adjacent tissues, referral of patient to an Oroantral oral and maxillofacial region. Supportive measures. Antibiotics. The prime objectives is preservation of secondary infection, control of existing or pre-existing Penicillin and its derivatives. Penicillin V 250 to 500 mg 6 hourly. If patient is penicillin resistance, broad spectrum of antibiotics is given. Ephedrine nasal drops 0.5% instilled intranasally every 2 to 3 hours. Intranasally every 2 to 3 hours. Steam inhalations, benzoin and menthol analgesics includes NSAIDs, aspirin 500 mg, 1 to 3 table tablets 4 times daily. Paracetamol 500 mg TDS. Ibuprofen 400 mg TDS. Temporary therapeutic measures before surgical closure. Temporary therapeutic measures affect satisfactory repairs include whiteheads, varnish pack, denture plate. Pack is a strip gauge or ribbon gauge is used to pack over socket the socket and secured with sutures. Whitehead's varnish pack, benzoin 10 parts. Whitehead's varnish pack can be made by adding benzoin 10 parts 44 gram, storax 7.5 parts 33 gram, balsam of Toulouse 5 parts 22 grams, iodoform 10 parts 44 grams, solvent either to ether to 1 flows or 100 parts. Denture plate, it indicates when surgical repair of fistula is to be deferred. The purpose of appliance is to provide a barrier to prevent entry of food particles into the antrum. A well-fitting denture plate is constructed to entirely cover the opening. Treatment of delayed cases. Treatment of delayed cases. Treatment of oral antral communication within 24 hours of accident. If the case of oral antral communication is seen within 24 hours of the occurrence, and the age of wounds are clean, it should be closed immediately. Post-operative treatment of post-operative treatment of antibiotics, nasal drops, and inhalation prescribed. If case is not complicated by displacement of tooth or a root tip into the antrum, can be closed by buccal flap and sutured under LA. The complicated case treated by immediate surgery in operation theater under GA. Treatment of oral antral communication seen after 24 hours of accident. After a period of 24 hours, the soft tissue margins of fistula often get infected, treated as prophylactic measures, antibiotic, analgesics, and decongestant. If there is purulent discharge from fistula or the patient develops acute or chronic signs of sinusitis, then the maxillary sinus should be gently irrigated with warm normal saline. Treatment of long durations oral antral communication. In these cases, surgical closure is required. Surgical procedure used in closure of oral antral communication. The surgical procedure performed in these cases, surgical closure is required. Surgical procedures used in closure of oral antral communication. The surgical procedures performed into three groups depending upon the type of flap used. Buccal flap, palatal flap, combination of both. Buccal flap, buccal flap advancement operation, intranasal anstrotomy, antrostomy, buccal flap advancement operation. It was described by von Rehrman in 1936. It is the most satisfactory method of closing of oral antral communication. This diagram showing the procedure of oral antral closure by buccal advancement flap using modified Raymond procedures. In the first picture, you can see oral antral fistula. Second picture showing outline of buccal flap. Third picture shows the markings of the outlines of buccal flap. Fourth and fifth pictures shows the reflection of buccal mucoperiosteal flap, relieving incision high up through the periosteum is given. Sixth picture is showing sagittal section Rehrman buccal flap. Seventh picture is showing modified Rehrman flap with de-epithelialized of the margins of the buccal flap, which is tucked under the palatal flap. Over the periosteum. This ensures double layer closure. Buccal and some palatal alveolar bones are reduced with rongers. Initial mattress suturings to pull the margins of the flap and then interrupted suturing is carried out, which is shown in the figure 8. Procedures: injection of local anesthesia to reduce the local capillary bleeding, 3 to 4 mm incision made around the fistulous tract with a fresh blade of number 11, 2 divergent incision made from each side of orifice in buccal sulcus for distance of 2.5 centimeter with a blade number 15. Advancement of buccal flap in situation where the buccal mucoperiosteal flap falls short of covering the fistula. Carefully inspect the area or maxillary sinus for evidence of infection. Complete arrest of hemorrhage. The mucoperiosteal flap is sutured into position. Post-operative medications are antibiotic, analgesics, and nasal decongestant. Restrictions of soft diet. Instruction to patient to avoid sneezing and to explore avoid explore the world with wound with tongue, to avoid nose blowing in early stages, to avoid nose blowing in early stages, removal of sutures 7 to 10 days post operatively. Patient is revived regularly to observe progress clinical and radiographically. Let's take a 15-minute tea break, then we will continue the webinar. So let's get started with intranasal antrostomy. Intranasal antrostomy can be performed by removing approximately 1 centimeter of medial wall of antrum, which bulges into the sinus below the level of inferior turbinate. These are the figures showing intranasal antrostomy. In the first figure, the posterior wall of antrum is visible. In the second figure, the medial wall of sinus bulges into the antrum below inferior nasal meatus. Then opening of the maxillary sinus takes place. Then antrostomy to the level of floor of nose is performed up to inferior meatus. Antrostomy is completed. Packing with ribbon gauge or iodoform gauge is given. End of the ribbon gauge brought out through the nasal antrostomy into the nostril. Procedure: a small sized gauge is pushed into the maxillary sinus through the inferior meatus in the nasal cavity. A big curved artery forceps is passed through this opening, and ribbon gauge end is grasped into its beak and pulled out into the nostril. Here's a single knot which is put in the ribbon gauge will help to keep it secured in the nostril. Other end used to systematically pack the maxillary sinus cavity in multiple folds. After achieving proper hemostasis, an antrostomy can be performed by removing approximately 1 centimeter of medial wall of antrum. Palatal flap treatment. Rotational advancement flap operations, and second is Ashley's operation. Rotational advancement flap operation is technically slightly more difficult than buccal flap operation. This operation provides adequate mobility and tissue bulk to the flap. It requires the mobilization of large amount of palatal tissue. Krugers suggested a V-shaped excision of lesser curvatures of the flap to minimize folding. Ashley's operation: injection of local anesthesia is given, excision of fistulous tract is done, marking out of proposed palatal flap is done, raising a palatal mucoperiosteal flap, maxillary sinus is inspected and cleared of polyps. Trimming of buccal mucoperiosteal, rotational advancement of the palatal pedicle flap to approximate the buccal margin with interrupted sutures. Ashley's palatal pedicle rotational advancement flap for closure of oral antral fistula. Circular excision of tissue around the fistula is given. Palatal rotational advancement flap based on the greater palatine vessels. The kinking of the flap may be minimized by excision at lesser curvature of the flap, darker area, Kruger's modification. Final closure done by palatal area can be protected by placing iodoform gauge pack. Combination of buccal and palatal flap technique. Cardwell Luck operation. It was given by George Cardwell in 1983 from New York, described as method of gaining entry into maxillary sinus via canine fossa with nasal antrostomy. In this figures, it shows combined local flaps of closure of oral antral fistula, hinged buccal and palatal rotational advancement flap. A and B. Inversion flap A and palatal rotational flap B. The hatched area is excised to facilitate the rotation of the palatal flap. Semilunar incisions are given for cardinal lung operation, creation of bony window with drill using postage stamp technique, perforation area for the window is created, enlarging the bony window at anterior maxillary wall with ronger or burr is done, and hence gain the access into the maxillary sinus through canine fossa. Indications of Cardwell Luck operation are open procedure for removal of root fragments, teeth, or foreign body to treat chronic maxillary sinusitis, removal of cyst or benign growths from the maxillary sinus, management of hematoma in maxillary sinus, zygomatico-maxillary complex fractures involving floor of orbit, removal of impacted canine or impacted third molars. Procedures performed under local anesthesia with sedation or general anesthesia. A semilunar incisions in the buccal vestibules from canine to second molar area. A mucoperiosteal flap is elevated with the help of periosteal elevator till the infraorbital ridge. An opening is created in the anterior wall of maxillary sinus with the help of chisel, gauze, or dental drill. Pus should be sucked away from the sinus. A thorough irrigation of maxillary sinus is carried out with copious saline wash. Inspection of maxillary sinus and removal of root, tooth gouge, cotton or bone wax, etc. The thickened infected lining of maxillary sinus can be elevated with Howard's periosteal elevator. If there is profuse bleeding, then the sinus can be packed with ribbon gauze soaked in adrenaline for 1 to 2 minutes. The antral cavity again is irrigated and can be packed with iodoform ribbon gauze. The incision is closed with 3 seal. Post-operative management are antibiotics for 5 days, analgesics for 5 days, tincture benzoin inhalation 3 times a day followed by nasal drops. Patient is instructed not to blow the nose, have soft diet and no vigorous gargling. Post-operative treatments plan or management. The patient should be instructed not to eat hard food items. They should eat soft food items and drink fluid from the opposite side to avoid trauma to operated site. Strenuous physical activities which can increase the intrasinusoidal pressure should be avoided until healing occurs. Nose blowing and sneezing with closed mouth is prohibited for 2 weeks. Patient should open mouth while coughing or sneezing. Patient should not roll tongue over suture line or flap for 7 days after surgeries. The wound should be kept clean with warm saline mouth rinse. Use of straw or smoking is prohibited. Use of steam inhalation such as menthol or benzoin 6 hourly moistens the airway and stimulates serous glands activity, preventing crusting of blood and mucus. All patients should receive amoxicillin plus clavonic acid 1 gram twice daily or clindamycin 300 mg 3 times for at least 5 days. And decongestant nasal drops or Trivin. Nasal decongestant shrinks the nasal mucosa and keep the antral opening patent for drainage. Non-steroidal anti-inflammatory drugs should be prescribed for pain control. Closure of oral antral fistula is significant problem considering the undesirable consequence of sinus infection. Impossibility to perform implant rehabilitations or pre-implant surgery procedures at the time oral antral communication develops. If the sinus is not infected and a normal blood clot formation occurs within the socket, spontaneous closure is most likely. However, spontaneous closure is put at risk by perforations less than 4 mm in diameter, socket depth more than 5 mm or soft tissue damage at gingival margins. Small perforations through healthy tissue will show good prognosis for primary healing. Only if the socket is blocked with satisfactory blood clots. The blood clot formed should be protected against dislodgement. If sufficient tissues are available, primary closure should be done by gauge. Sponge should be placed between the jaws to protect the blood clot. While discharging the patient, instruction to minimize clot dislodgement should be given. Gel foam should not be inserted in the socket as it will swell up and may penetrate into soft sinus, affecting the healing process. There are two basic principles that must be considered while operating oral antral fistula or oral antral communication. The first is that the sinus must be free of any type of infection with adequate nasal drainage. The second is that closure must be tension free and consist of broad-based, well-vascularized soft tissue flap over the intact bone. Successful closure of the oral antral fistula should be preceded by the complete elimination of any sinus pathology, the fistulous tract, sinus infection, degenerated mucosa, and diseased bone. The success rate of immediate closure of acute oral antral defects has been as high as 95%, but secondary closure of oral antral fistula has low success rate as low as 67%. Thank you.